want to work with the pubofemoral ligamentous tissue with your patient, you're going to want to have them, one way that you can have them is in a supine position. Now, we work with the pubofemoral ligamentous tissue in a very specific range. You need to get that hip and engage that tissue into 50 degrees of abduction before you actually fully engage all of the ligamentous tissue of that structure. We're also going to be engaging with anything that works in series with that structure also, so you're going to be making contact with the adductors, with iliopsoas, with iliacus, anything that crosses over and again becomes or works in series with that pubofemoral ligamentous tissue, you're going to be engaging with it. So again, we want to have our patient in supine position. We need to get that hip into abduction in order to engage with the full ligamentous tissue of that tissue. But what we also want to do is we want to try and drive the head of the femur in an anterior position in order to reestablish a proper force coupling mechanism of that joint. In order to assess the force coupling mechanism of the joint first, what we're going to do is take our patient's knee, providing that they don't have any issues with the knee. We're going to slowly take our hand underneath, and then we're going to try and externally rotate the head of the femur or the leg out to see if there is a proper sliding and gliding that occurs within that femoral acetabular joint capsule. If there is a good sliding and gliding mechanism, well then you can go and treat some other tissues. But if it feels like the head of the femur starts to roll posteriorly, then we know that that force coupling mechanism isn't functioning efficiently. We need to drive the head of the femur more anteriorly because that's the general direction, the normal direction for that force coupling mechanism. So, working with the pubofemoral ligamentous tissue, what I like to use is a nice Kong. You can buy this at a pet store. It's nice and cheap, it's plastic, it works great. Now remember that we need to get the femoral head or that femoral joint capsule into 50 degrees of abduction, but we also need to drive it anteriorly. So what I want you to do is I want you to slowly place a Kong or a foam block underneath your patient's femoral acetabular joint capsule. And then what I want you to do is gently take their leg into 50 degrees of abduction. And this is the position that you're going to be in for the treatment technique. Now, if there is a lot of neural engagement for that joint capsule, for the adductors that work with the work in series with it, there's going to be a lot of protective mechanisms and guarding into this area. So really what we want to do is just allow enough time for that protective mechanism to relax. If you wanted to incorporate a muscle energy technique with this, you would have your patient abduct their leg inwards a little bit for maybe 3 to 5 seconds and then have them relax. You can then elongate a little bit more of the tissue, but you can see how we're getting an increase in length or in space where this pubofemoral ligamentous tissue is living in, and we're also using the Kong to drive the head of the femur in an anterior position to recreate proper force coupling mechanism. When this gets to the point where you get a lot of range, you are getting a lot of elasticity and not a lot of resistance, then what you can do is slowly take the force off of the head of the femur. You can take the Kong out from underneath their posterior femoral acetabular joint capsule. You can take their knee back up, put your hand back underneath, and reassess for that force coupling mechanism of the femoral acetabular joint capsule. And you should be able to feel that that no longer rolls posteriorly, but it actually rolls anteriorly, and you've recreated the proper force coupling mechanism for that joint. And let's see what this looks like with our patient on the table. So with working with the femoral acetabular joint capsule and ligamentous tissue, we want to be aware of the force coupling mechanism that the femoral acetabular joint goes through. There should be a roll and glide that occurs in through that joint, but sometimes with patients that have got long-standing chronic issues or acute issues where they've had a lot of neurological engagement, what you can get is more neurological engagement and protective mechanisms in one aspect as opposed to another aspect. And instead of getting this roll and glide that occurs, sometimes you just get a roll that occurs, and then the joint doesn't have the ability to glide in the opposite direction. So with working with pubofemoral and the joint capsule, what we like to do is assess to see if there is a proper force coupling mechanism of that joint before we treat it. So the way that we check this is we bring the affected leg into neutral position. We stick our hand underneath the posterior aspect of the greater trochanter, and then we slowly abduct the hip or the leg out externally. And what I'm looking to see is if the posterior greater trochanter actually falls back into my hand or if it drives anteriorly away from my hand. And with hers, it actually drives posteriorly into my hand. So instead of it rolling and gliding away this way, it's actually rolling and gliding inferiorly or posteriorly back into my palm. So what we're going to do is we're going to place a wedge underneath the hip in order to drive the head of the femur more anteriorly, recreating a proper force coupling mechanism for that joint. So what I do is I take a Kong, and I just went to the local pet store and bought a Kong because it's an appropriate size and it fits almost everybody. And what we do is went to the pet store. Sometimes we can stick peanut butter in this. Exactly. So I'm going to stick the Kong right underneath the posterior greater trochanter of the femur. And that is going to provide the stability for that femur to be drawn anteriorly. And as we slowly abduct, we'll just take it to the point where there is some tissue resistance. Now, there may be some engagement of the adductors that we can work with in a later video, but for right now, we just want to provide the body a sense or an input that it should be driving the head of the femur anteriorly into the front of the pelvis, which is the normal force coupling mechanism for this joint. If you wanted to incorporate a muscle energy technique into this ligamentous articular strain technique, then you could support at the distal end of the femur and just adduct in 10%. Hold it there. So as she does this, her musculature is driving the head of the femur anteriorly, and then relax. And as she relaxes, I'll provide a little bit of an engagement, again more into abduction. Doing okay? I'm going to hold it here. We'll do another little muscle energy technique, so then press in. Hold that, just 10%. And then relax. What we like to do is just hold these for about 3 to 5 seconds. Again, it's a nice neurological potentiation. It's a nice neurological engagement that's a safe range for it to get into. And adduct again, 10%, just there. And then relax. A little bit more engagement this way. Doing okay still? Mm-hmm. Good. And then one more adduct in. And relaxed. A little more of the lengthening. And then what we'll do is we'll slowly, so you just relax. So we don't want them to engage their adductors in order to help us bring the leg back into place. We are going to passively bring the leg back into place. We're going to take the Kong out, and then we're going to reassess. So again, hand at the posterior aspect of the greater trochanter of the femur. We're going to slowly take this leg out, and now I can get a lot further into abduction, and that posterior greater trochanter does not contact my hand whatsoever. I can feel that the head of the femur actually drives very far anteriorly. So that's a nice technique for pubofemoral, but we also are aware that anything that crosses the joint we're also gaining access to. So we're gaining access to hip flexors, adductors, gracilis, pectineus, brevis, longus, adductor magnus, all of those musculatures. And they all work in series. So if you can actually engage pubofemoral, then anything that works in series with pubofemoral, you're going to gain access to and benefit from also. So that is the technique for pubofemoral ligamentous tissue.